Sir, over to you.
Here to get your attention here to get your attention to have active participation from the audience side, volunteer participation. It's more of a practical topic rather than more of a theory. Theory mostly related to the surgical side. So we will mostly discuss regarding the practical aspects. Two slides on what basically is a tracheostomy. Tracheostomy is a surgical procedure which is done to create a window, that is the stoma. The stoma is nothing but an opening which is done anywhere in the body. Here, a surgical window which is created with the anterior wall of the trachea, which is then connected to the exterior. Here you can see here. So, if this is a site of tracheostomy, tracheostomy opening here. If there is obstruction anywhere above, generally above the level of vocal cords, generally the tracheostomy is done below the level of obstruction. So what is tracheotomy? Tracheotomy is the opening which is made in the trachea, and tracheostomy is an entire surgical procedure which is done from the skin direct down to the trachea. So what is tracheotomy or laryngotomy, or it is also known as goniotomy? That is, it is a mini tracheostomy which is done in an emergency procedure where an opening is made between the cricoid and the thyroid cartilage. The opening is very narrow, which has to be later converted into a regular tracheostomy. The landmarks here are, this is the thyroid cartilage, which is the most prominent landmark in the neck. The opening for the prominent, you can see here, is the Adam's apple, or known as the thyroid notch. The notch are seen here. The other prominence which you are feeling here, the second most prominent is the cricoid cartilage, which is the hardest or the toughest cartilage to the entire airway network. So the space between the thyroid cartilage and the cricoid is completely avascular. There is no blood vessel except between subcutaneous tissue and directly on the membrane. So in case of an emergency, this is a very small space. When there is complete airway obstruction, in an emergency procedure, we make this opening and then later we convert it into a regular tracheostomy. But most of the time, we trained surgeons will be able to do the procedure entirely in 30 seconds. So rather than doing a laryngotomy, we directly go to do a tracheostomy. Laryngotomy is a procedure I think most commonly, most of you people would have seen the movie Vessel. So even Suresh sir would have highlighted it in his previous slides. So the functions of tracheostomy are basically the indications of tracheostomy. So you see, this is the level of vocal cords. If there is any obstruction above the level of vocal cords, we generally find an airway obstruction. So when there is an airway obstruction, we generally do a tracheostomy to bypass that airway obstruction. It may be also assist in prolonged assisted ventilation. That is, when we anticipate a patient to be on ventilator for prolonged periods. Thus, when there is an airway obstruction, the maximum resistance is seen at the level of vocal cord, at the level of base tongue, at the level of soft palate and the teeth. So when these are bypassed, the airway resistance is reduced. Thus, it will reduce the dead space. When the dead space is reduced, the effort the lungs has to put to breathe is very less. So with minimal breathing efforts, the patient can breathe. It also helps in tracheobronchial toileting and inflammation. That is, if there are retained circulations or pus which is then collecting inside the lungs, we can put a tracheosuction tube and suck out the secretion, which helps in tightening of the lungs. And lastly, it may also be necessary as a part of surgical procedures where they may not be able to intubate from either from the oral cavity or from the nasal cavity as a part of giving anesthesia. So the indications of tracheostomy are basically divided into two types. One is obstructive, the second is non-obstructive. So the obstructive ones are the ones which I mentioned above. That is, there should be an obstruction above the level of vocal cord, normally. So briefly the indications are from the obstructive side are all causes of stridor. What is stridor? Stridor is a noisy breathing which is caused as a result of airway obstruction. The stridor may be expiratory, it may be inspiratory, or it may be bilateral. So the most common causes of stridor may be seen at the level of oral, pharyngeal, laryngeal, or tracheobronchial tree. It may be intraluminal or extraluminal. It may be congenital or inflammatory. We have this only one slide on this. Or it may be non-obstructive. The most common obstructive causes at the level of larynx, congenital are laryngomalacia. Here you can see here, this is the case of laryngomalacia, wherein the epiglottis is entirely collapsed. We are not able to see the vocal cords, so we will not be able to intubate from above. When we are not able to show what is the level of vocal cords, we will not be able to move the tube inside. So this is an emergency condition where we have to do a tracheostomy. This is a pediatric case. The second case is a case of laryngeal stenosis, where one half of the larynx is not entirely visualized and the airway is narrow. It may be a case of laryngeal wave, or as shown in the last slide, it may be a case of laryngeal tumors. Among the inflammatory conditions, it may be any case of any upper airway respiratory tract infection, most commonly acute epiglottitis or diphtheria, which is most commonly known as bull neck, or maybe seen in a case of laryngeal edema. It may be also seen in case of trauma, which may be treated to foreign body, or any corrosive poisoning leading to airway edema, or in cases of maxillofacial trauma. From the neoplastic side, in the case of obstruction or there is malignancy arising at the level of larynx, or it may be a case of juvenile laryngeal pulmonymetasis, or it may be any neurological condition where there is poor respiratory effort. So at the level of tracheal, the most common congenital conditions are atresia, that is the entire lung is not fully developed, or there is a tracheoesophageal fistula, that is there is a connection between the trachea and the esophagus. From the inflammatory side, any upper respiratory or lower respiratory tract infection, trauma, most commonly the neuromaxillofacial trauma. And then from the neoplastic side, it may be related to any malignancy arising from any level of trachea or the bronchus. So I said among the classification, extraluminal and intraluminal. The previous ones were intraluminal, that is compression which is coming inside the lumen. So there may be also compression coming from outside the lumen. The common congenital conditions are abnormal vessel. If there is any abnormal vessel causing compression on the airway, it may be due to any abnormal vessels or mediastinal tumors. From inflammatory conditions, mediastinitis, pneumomediastinum, or any parapharyngeal abscess, or most commonly in the ENT side is Ludwig's angina. Trauma, when there is rib fracture leading to pneumosternum or hematoma inside the neck, or any thyroid malignancy which is causing compression of the trachea, or any mediastinal tumors or lymphoma. This is a case of surgical emphysema, where the trachea which is to be seen in the right side is entirely pushed. Where the trachea has to be inside the center is pushed to the right side. So the non-obstructive indications are mainly for assisted ventilation, where in ICU setup, mainly for patients who are on ventilator, for assisting for the tracheobronchial toileting, just to maintain to suck out the secretions, to prevent aspirations, and then as a part of giving anesthesia during on-table procedure during surgery, and it may be done as a part of a total laryngectomy patient, where the entire larynx is removed and the pathway of the trachea is connected to the skin for a breathing pattern. So where do we see assisted ventilation? Assisted ventilation is commonly seen in higher centers and patients who are in comatose patient. They may have an head injury or a CPA or an encephalitis. From the respiratory side, there may be bulbar paralysis, barbiturate poisoning, OP compound poisoning, or any other neurological conditions related to the entire neuromuscular system. So the previous slides were mostly related to the medical side. Here onwards, I think mostly will be more related to the practical side. So the types of tracheostomy based on the timing. Tracheostomy can be divided into an elective, an emergency, or a semi-elective. Elective is a planned procedure which can be done either from today, tomorrow, 1 week later. The patient is either a conscious patient as a part of a surgery, or if the patient is a ventilated patient with the consent of the attenders. In a case of emergency, which has to be done within 5 to 10 minutes, or in a case of semi-emergency, within a period of 2 to 3 hours. It can be divided based on the duration, whether it is a temporary or a permanent tracheostomy. Temporary tracheostomy is where a patient has a oromaxillofacial trauma, or whether not able to intubate from above. We do a tracheostomy, secure the airway, and then once the obstruction or the procedure above has been completed and the airway is patent, we will be assessing if the tracheostomy tube can be closed, and then we'll be closing the tube. So that there it becomes a temporary tracheostomy, and permanent is when there is a malignancy of the larynx. We will have to do a total laryngectomy where the entire larynx is taken out. We create a trachea fenestration to the skin. That is, we bring out the trachea and suture to the skin, so that without the tube, the patient will be able to breathe, and you can see directly the tracheal rings here. Mostly, most permanent tracheostomy is mostly done in patients of post-laryngectomy patients. So the landmarks here, I already mentioned here, this is the thyroid cartilage, and the notch which we see generally in here is the thyroid notch. This is the cricoid membrane, cricoid cartilage. The space between here is generally known as the cricothyroid membrane, where we do a mini thyroidectomy. Mini tracheostomy. This is the thyroid, this is the left isthmus, the right isthmus, and the part connecting here is the thyroid isthmus. So the thyroid isthmus is a landmark for us to judge where we insert or where we make the opening in the trachea. That is, generally that isthmus lies corresponding to the second, third, and fourth ring. So generally we make the opening at this second ring. There is a junction between the second and the third ring. This is a normal site where we open. Sometimes we may have to do a higher opening. There is a junction between the first and the second ring. So then it is known as a higher tracheostomy or lower tracheostomy in case if the block or the obstruction is lower. I showed in one of the slides at the end. Where if the obstruction is lower, then we'll have to bring the tracheal opening still more down. Based on the technique of surgery, where we make excision of the surgery, and then if we make a slit in only the opening is made on the trachea, or if we create an opening and make a space, or if we make a head-shaped flap and then suture that flap back onto the skin. Based on that, also it is divided based on the technique of surgery. And then if it is an end tracheostomy, we'll have an end-to-end suturing. That is, the entire larynx is removed, and then we bring the entire trachea down to the skin and suture the upper end of the skin and lower end of the skin to the trachea. And based on the age, it may be an adult or a pediatric tracheostomy. So for people on the OT side, the position of tracheostomy is very important. Ideally, you can do a tracheostomy in any position, but the position is important mainly to make the procedure easy and fast. So we place a sandbag below the level of shoulder, so the head is hanging down. So what happens is the head is extended at the atlanto-occipital joint and as well as at the neck. This way, what tends to happen is the trachea comes upward. The other soft tissues will slide away parallelly, and the trachea comes up. But there is a drawback in this position. The trachea is a தமிழ்ல சொல்லணும் அப்படின்னா ஒரு பைப் மாதிரி. வீட்டில் தண்ணி போகிற பைப்பு, அதை வந்து காலை தூக்கி வச்சோம் அப்படின்னா அதில் வந்து ஒரு கம்ப்ரெஷன் இருக்கும். ஸ்பீடாக தான் போகுமே தவிர வால்யூம் போகாது. So once you put in extension, there will be a slight compression of the trachea, and then what will happen is the slide may worsen. So ideally, once the patient everything is ready, right from tracheostomy tube to surgeon to everything is being ready, then you put the patient in this position, particularly who are awake patients. There is no difference in patients who are intubated, but when a patient is in awake patients, ideally when everything is ready, you put the patient in this position before making a skin incision, or If in case there is an accidental decannulation or accidental removal of the tube, you have to put the patient back in this tube so the trachea comes up. You will be able to see the opening and then you can reinsert the tube. So the anesthesia which are generally used for the tracheostomy is mostly local. In awake patients, it may be general when the patient is intubated or on ventilated. The area of infiltration is in a rhomboid fashion, or generally we follow a triangular fashion. The landmarks will be at the lower border of tracheal cartilage, anterior border of sternocleidomastoid mastoid, anterior border of the other end of the sternocleidomastoid mastoid. So this is a small video which will show you the basic steps of tracheostomy.
VS strider. And this is a landmark for tracheostomy, is the Jackson's triangle. Lower border of the tracheal cartilage is taken and the apex is the suprasternal knot. And two sides are with the borders of sternocleidomastoid borders. The infiltration is given and we start up.
I think you have marked the landmarks here. This is the lower border of tracheal cartilage. This is the anterior border of the sternocleidomastoid of the left side. The anterior border of the sternocleidomastoid of the right side. The central incision is where we are going to give the incision. So the infiltration will be given so that the bleeding around where we make the incision will be less. Second, I have my own technique where we insert directly into the trachea to see how much the depth. So we don't have to be general life law ஒன்னு இந்த பக்கம் நில்லுங்க இல்ல அந்த பக்கம் நில்லுங்க சென்டர்ல நிக்காதீங்க அப்படி சொல்லுவாங்க. Tracheostomy is a life saving procedure. We always have to be in the center. You deviate from the center, இந்த பக்கம் போனீங்க அப்படின்னா will be hitting one of the carotid or the general IJV. அதே பக்கம் அந்த பக்கம் போனாலும் the carotid or the intrajugular will be very close to it. So always be on the midline. There is no shifting from the midline in cases of tracheostomy.
The surgery and the principle is we have to stick on to the midline always. As it is a stridor case, we have to be very fast and precise and to be in a avascular plane. And the incision is made 3 to 4 centimeters, starting from the lower end of the tracheal cartilage, few centimeters below it, until the suprasternal arch. So, using the Langenbach retraction. Intermediately, we have to palpate it, the trachea. These are the fascia, subcutaneous fascias and fascias are separated. Always stick into the midline. So this will make sure that be safe and not have any much complications. We observe a few bleeding which can be catched using the bipolar battery. So now all the bleedings are stopped and still we are retracting again and going below and the staples are fractured and fuse are dissected. Our motto is to reach the
white structure we see here is a trachea.
And that's it, we got the plane there. The single hook is held in superiorly. Few staples are being fractured. We observe a small vessel which comes in the midline. Rather than disturbing it or getting injured, dissecting below to it, and we make sure that small vessel is not injured, which will make a kairos to the surgical field, and it is retracted to. The loop is put in the lower end. We have clearly visualizing the trachea. Few more fascias attached to it. This is also dissected very gently. Make sure the trachea is not injured in wounded areas. So the tracheal rings are clearly visible, and the thyroid isthmus is retracted superiorly using a single hook. And this is a 4% lignodyne which confirms the presence of trachea, and few drops are into it to make the patient not to cough while opening up the trachea. Using the 11 blade, we made a transverse incision at the second ring. We are catching it using a Nally's forceps. Just we are making a window. Tracheostomy is made here. I usually catch the lower end of the trachea to make sure the tube while inserting will not slip out, and always it will enter into the trachea without any problem. So, catch over the tracheostomy tube, all the retractors which supported for that, and try the tracheostomy tube, and this is a confirmation of the tracheostomy tube inside the trachea only. Make sure it is tightly tied, and this is a case of emergency tracheostomy, so we have to be very fast or else we will lose the patient too. Secure the tracheostomy tube using sutures both the side of the tubes. This will make sure that the tracheostomy tube will be in situ, and the patient coughs also. There will be expression of the tube will be less chance. This is one of the procedure which saves the patient, and the ENT surgeon has to know how to do the emergency tracheostomy tube. It's mainly for
So how many of you all have seen, assisted or attended tracheostomy patients? Just put up your hands. It makes my job next easy. So basically what we are going to next discuss is the types of tubes which are on the table. Okay, based on the material of production, it may be metal or plastic. That is Vortex tubes. Most commonly used metal tubes are Jacksons and Fullers. The plastic tube is either it may be a cuffed or a non-cuffed tube. The cuffed tube may be a single cannula tube or a double cannula tube. So this is a plastic tube here. The first one is a Jackson's tube. The second one is a Fuller's tube. Can we have two participants, either from that side and one from this side, to take from tubes? I need two participants. I know most of you don't have seen the tubes there, but at least you can see what the tubes are. Better if people who are assistant or done with the tracheostomy tubes. Can take what you want. I'll go with that tube first. So you can see the tube has three parts. This is a Jackson's tube. The tube has three parts. Okay, the outer tube, the inner tube, and this is a trocar. Can you see three tubes there? Three parts there?
Oh, sir, only two only.
No, the third one is there inside. I'll tell you how to take that out. No, can you see? I mentioned, can you see that? I can ask you to take it. You can see three there. Madam. This is a Fuller's tube, which has an outer tube and an inner tube. There's a number here. There's a number here. I hope there's a number there also. Isn't it? 20.
26, sir.
This is a Jackson's tube, which is most commonly used in most of the cases in GHS in Tamil Nadu. The main advantage is the tube costs less than 100 rupees. There is a lock here. Unless you remove that lock, you will not be able to take the tube. Okay. And then put the lock back. You will not be able to take it go. Another thing is, both the tubes are the same level, isn't it? Both the tubes are the same level. So, if the tube gets occluded, the entire tube will get blocked, isn't it? So, why do you think this block, the lock is made? Just a common sense. Why do you think the block is Pardon? Where? Where do you see that? Patient conscious. Violent cough. Exactly. Patient is having violent cough, so we don't want the tube to come out. So, when we anticipate, this is one of the oldest tubes. We don't use this tube here now. Okay? But this is the alternate tube to the other. So, the lock is there. So, you need to know. If the tube is used, tube is blocked, you are trying to remove the tube, you will not be able to remove the tube unless you open the lock. Okay? So, open the lock here. Turn it down. Turn it clockwise or anti-clockwise. You need to turn it at 180 degrees. Remove the tube. Okay? What does this number indicate? What is here? Yeah, size of the tube. This 26, what? 26 inches, 26 kilometers, 26 meters, 26? 26 French gauge. These are French made tubes. Okay. What that indicates is the inner diameter of the tube. So in adults, both the sizes will be the same. In adults, males we generally use 32, 34, 36. In females, 28, 30, 32. Okay, we generally don't use metal tubes in pediatric patients. In pediatric patients. One more. What is this one? Blockage the airway. No, this is used to introduce the tube. Guide wire. This is a trocar, not outsider. This is a trocar. When you are intubating through endotracheal tube, we generally pass a bougie through the endotracheal tube just to act as a guide. Because the tube will be moving around. This will just act as a guide. The same trocar is available in the plastic tubes also. So this is a trocar. We insert it, take it out, then put the metal tube. What is it?
This is the fenestration, I think so. It's an inner tube, yeah, and this is the outer tube, and it shows in the display it is 32. It is for the female, okay, and
we can use it for male also. Small belt indicates the size.
okay.
So if a person asks what is the size of the tube to be used, you need to see, like for in a plastic tube, it will be mentioned either in the cuff or at the back end.
Okay.
But here in the metal tube, it will always be back. No one will be willing to see what is there in the back.
Okay.
So the size of the tube will be mentioned in the back always, in case of metal tubes.
Metal tubes.
Okay. So this is a biflange tube. You can see two flanges here, no?
Yes, yeah.
Two flanges here.
Yes.
Okay, you can see two
That's
flanges here,
it.
one fenestration here,
Yeah.
inner camera here.
Yeah.
What other thing else you can see here? Here. Compared to that tube. No, I like your plan. Is the
Oh, yeah, inner cannula is a little bit lengthier than the outer
So
cannula.
what may happen here, or what is the advantage of this tube over that tube?
This may include the
No. In case of it gets blocked, I said both those tubes are the same level,
okay.
isn't it? So if the tube gets blocked, the entire tube is blocked.
Here it is.
Okay? If the tube gets blocked here, what will happen here?
You
This
can
tube is
use-
blocked.
So you can remove the inner
Remove the
tube and
tube,
it is, so the block can
The
be.
path will be still patterned. Okay?
Yeah.
This is the same mechanism we are using in the plastic. Okay? This other advantage is this has a hole here. isn't it? So if the patient wants to speak, close the block here, air will enter through here, and patient will be able to vocalize. But that cannot be done with that Jackson's tube. Okay, so but both these tubes cannot be inserted and cannot be ventilated. Ventilated in the sense you cannot keep the patient on a ventilator or you cannot arm him. It's not possible. Okay, so there is lot of leak here. You cannot connect anything here. This can be only done in patients who are awake, planned for discharge, or when you are planning for a closure. So you need to know the number. You need to know what type of tube. Jackson generally we don't use nowadays. So fuller tube is used mainly when you are planning to close the tube. So it has two flanges. The inner tube to be taken out in case there is a block. Still the airway will be patented. And then the inner tube has a cannula where the inner tube, if the patient wants to speak, he can just occlude and then patient will be able to speak. Can we have one more person regarding the plastic tubes? Mr. Joseph can take up. So the parts of the plastic tube are the neck flanges, the mouthpiece to which we connect the ventilator. We have a cuff here, the neck piece which goes into the trachea, the obturator, the cuff to inflate the bulb. It may be an uncuffed tube and it may be a fenestrated tube. The difference between this tube and this tube is this is made of silicon, which is alternately known as a stylish tube, and this is a Portex tube. This is a stylish tube. This is a slightly expensive tube which costs around 5,000. This tube will be roughly around 2,000. This tube generally we don't use in Indian setting mainly because there is a penetration here. We use mainly in ventilated patients. Even if the patient wants to speak, he has to first occlude. Patient is on ventilator, so there is no point in having a penetration at this point when the patient is on a ventilator.
This is the cuffed tube and the cuff inflator. Cuffed tube and cuff inflator, and this flanges to fix on the over the skin, and this is suctioning. Yeah, through this we can suck the secretions.
Without inserting through the cannula, we can do an external suction.
External suction we can do, and this is
The obturator which we had in the Jackson's tube.
yes, the same thing.
As a guide to
Guide way.
trachea.
Yeah. And this is the inner cannula.
This is a newer concept where
Yeah.
we have inner cannula, same as the fuller tubes. Instead of in case the tube gets blocked, we can insert. So what we practice in our ICU, we always use when the tracheostomy is done within 4 to 6 hours, the inner cannula will be inserted.
The locking system also is there, and so you can see that one. So when you are unscrewing, you can remove the inner cannula.
Then
Yeah.
the tube.
Pardon?
Then the tube.
The tube.
It's always slightly 1 to 2 millimeters.
Yeah, okay. Okay, yeah.
So this is a cuff. How do you make a cuff? you put? Huh? How do you calculate? There is no fixed rule 5, 2, 10. Okay, it depends on the size of the trachea. நம்ம tracheal incision கொடுக்கும்போது size எவ்வளோன்றது நமக்கு தெரியும். Availability of the tube. பெரிய ட்ரெக்கியாவாக இருக்கும், பட் ஹாஸ்பிட்டலில் 6 size டியூப் தான் இருக்கும். அங்கே 8 size டியூப் போடலாம், பட் 6 size டியூப் தான் இருக்கும், அவைலபிளாக இருக்காது. பிகாஸ் இட்ஸ் an emergency procedure. அந்த டியூப் வாங்கிட்டு வர வரைக்கும் நம்ம வெயிட் பண்ண முடியாது. தென் யூ ஹேவ் டு இன்சர்ட் ஹை வால்யூம். இஃப் இட் இஸ் அ ஸ்மால் பிகர் டியூப், 8 size போட ட்ரெக்கியா டியூப்ல நீங்கள் 6 போட்டிங்கன்னா மோர் வால்யூம் யூ ஹேவ் டு இன்சர்ட். பட் 8 size போட ட்ரெக்கியா டியூப்ல நீங்கள் வந்து 8 போட்டிங்கன்னா தென் யூ மே நாட் ஹேவ் டு இன்ஃப்ளேட் ஆல்சோ. ஸோ there is no hard fast rule. You have to inflate with 5 to basically entirely clinically customized. Just inflate the balloon. Inflate with 10 mm. There's no patient here. No, inflate with 10 mm. That's what I'm trying to say. You just feel the pressure. How much you have inserted? 10 you have inserted. You are feeling the pressure, man? Not much. Okay, 1 second. Generally we insert 8 to 10 mm. Generally I am saying. Okay, nothing more than 8 to 10 mm. No condition, nothing more than 8 to 10 mm. Unless we are in a condition where there is very small size tube, very sick patient, or there is bleeding, excessive bleeding, we are anticipating long-term aspiration, not more than tube. More than, see, this is if we are choosing the correct size of tracheostomy tube, then this size is more than sufficient to achieve a good seal for ventilation. This will also prevent aspiration. This is more than sufficient. Just insert 10 more. You hold, man. You feel the pressure. These are high, similar to endotracheal tubes. High volume, low pressure. The entire blood supply of the trachea comes from up to down. Okay, so even if you insert 50 ml also and 10 ml, the pressure difference will be not much. It doesn't indicate that you have to indicate 50, insert 50 for all the cases. Even if you insert 10, even if you insert 50, the pressure inserted over the trachea, because surface area is high, at one point the pressure inserted is very less. So these are high volume, low pressure, so that the trachea doesn't get injured. It's very fragile structure, trachea. So the more pressure you insert, the more duration the cuff is on, the more duration the blood supply will be cut, the chance of going for tracheal stenosis will be high. You take the tube out, the trachea will collapse. So ideally 8 to 10 ml. Okay, and I'll later tell you how to deflate the cuff and do a suctioning also. Okay. So this dressing is very important. So once we tie, insert a finger through this so that it doesn't cause any pressure necrosis. The dressing around the tracheostomy tube prevents any secretions coming out through the stomach, because it is an open wound, and then because of the pressure created by the tracheostomy wound on the skin, there may be maceration, and then from there it may be leading to gaping of the wound, and the wound may open up further. So this dressing has to be done daily, irrespective of suctioning. The dressing has to be daily done as we do a routine nursing care. So the post-op care is basically, it has to be aseptic and has to be on a to be done on basis of a barrier nursing type. Typically, you will have to check the position and the patency of the tube. Position of the tube. When the patient is on the ventilator, there is always a pull from the ventilator. So the tube may get displaced. So you have to repeatedly check that. That's why we just make sure the tube is not too tight, too loose. The tube is too loose, it will get displaced. If it is too tight, there will be necrosis around the entire neck. So when there is a pull around the neck, when you do suctioning, so what we have to check is the tube is in position. How do you do that? Is see if air entry is equal, or you see on the ventilator machine the adequate tidal volume is being delivered. The tube may get also displaced, in particularly in awake patients or in restless patients. for trying to pull the tube out, like when they try to pull the ventral out. So regarding the cough management, how much air to inflate? I think I have briefly told on that. Then how frequently to deflate the cuff? That is very important. Once the tracheostomy is done, for the first 24 hours, you deflate the cuff for every 4 hours. For the first 24 hours. For the first 24 hours, you deflate the cuff for 4 hours for 5 to 10 minutes. So when you deflate, the blood supply for the entire trachea and the bronchi will come. Then during that 5 to 10 minutes, without wasting time, you can do the suctioning. Okay? So you deflate the cuff, do the suctioning and inflate. So the entire process will be 10 minutes. You will be covering both the deflation process as well as the suctioning process. So how frequently do you do the tracheostomy suctioning? Any answers?
Whenever we are seeing the more secretions, we can do the suction. And at the same time, it is every 4 hours, 24 hours, every 4 hours that when we are deflating, we can do the suction. That's all.
Any other answers? Okay. No, there's nothing to, somebody could say a wrong answer, but you want to learn it, right? We have seen people suctioning hourly also. We have seen people suctioning every 30 minutes also. We have seen people don't suction for 1 week also. That's why I'm just asking, how frequently you think you have to suction? Okay, once you are suctioning, what happens? What is sucking? Everyone is agreed on that? No, I just asked. When you are sucking, what you are sucking? Secretion. Exactly. So when you are sucking, removing the oxygen at the lungs level also. So never repeatedly do suctioning. Okay, suctioning has to be done either samely. When you are doing every 6 hours, it's like tablet, TDS or on BD. Or if the patient is in distress, shows ventilator shows there is a blocker, or the patient is conscious, he is complaining of breathing difficulty, then do a suction. Not every hourly, every second hourly, there is no hard and fast rule. Ideally, every 6 hourly. Ideally, for the first 24 hours, every 4th hourly, and then for the next 7 days, for 6 hourly is more than sufficient. After that, you may not even have to do a tracheostomy suction. So, both of these, the cough management and suctioning, almost the same. You have to deflate the cuff every 6 hourly. You have to do the suctioning for 6 hourly. You have to do this in for 5 to 10 minutes, so you can club the work and do it. So you first deflate the cuff, do a tracheostomy suctioning every 6 hourly, inflate the cuff after 5 to 10 minutes. So what is the technique of tracheostomy suction? We generally put a tracheal catheter inside the tracheostomy tube and then suck the secretion and put it in a saliva. I hope that everyone is doing the same thing, isn't it? What tube is used? No, I'm just asking regarding the suctioning technique. Why rotated? No, let's finish off. What material is used? No, suction catheter is made of? It's a plastic tube. Yeah, PVC tube. Plastic tube. So the end of the suction catheter, if you see, it is not smooth. It will be a bevel edge, like a syringe. Okay? This is a vision procedure done under vision or blind procedure. So it's a blind procedure. You are not sure how much you are inserting. So what will happen? You insert it repeatedly and the injury occurs at the same point. Around the tube or below the tube, there will be multiple granulations. Once you take the tube out, that will entirely collapse. Or once the patient starts coughing, there will be blood-stained secretions. Then patient or caring staff or doctor, everybody will be under panic why there is a blood from the stained spot. So ideally, the recommended material is the Portex one. But we and our hospital use a, what is this? we use a Foley's catheter. This is a Foley's catheter. This is a atraumatic one. So, yeah. So how much do you insert it in? Awake patient and patient who are on ventilator. You are inserting. Now you have chosen the material. This is atraumatic. Now how much you insert it in? It's a blind procedure, right? So how do I know I have reached the trachea? Okay, now I will not be able to know. 2 points. One is if an awake patient till he coughs, that is, it has to just to go beyond the tube, not till the level of, you cannot go till the level of your distal bronchi and suction. That can be done only under the guidance of a fiber optic examination. This is, you are doing a tracheobronchial suctioning only, or tracheal suctioning only. You are not doing a tracheobronchial toileting, where we can do it only under fiber optic guidance. Here, you insert the catheter, it will just go beyond that. If the patient is awake, he will immediately stop coughing. That's point number one. Point number two, in case if it is a ventilator, there will be no cough reflex. So, other alternative is, you insert till you have a resistance. What is that resistance? Yeah. Then the resistance is where you have the carina. See, in life, people tell that when you try to pull something, it is not coming, just leave it. You try to engage and pull something, it will create more trouble. When there is resistance, don't go beyond that. Just come above that. And in a circular manner. Okay? Always in a circular manner is because if you try to pull it directly, the tube will come out suddenly and hit some unsterile area. So what you do in a circular area, it will be under your control. Okay? So you can easily pull the tube. If you want a resuction, you can use the same tube pack, or rather than using one more tube. Okay?
This is a case of emergency tracheostomy done for a supraglottic tumor who presented with a
Second video, other video.
This is Dr. Narendra.
Begin by opening the catheter and connect it to your portable suction. Remove the packaging and turn on the portable suction. To ensure the catheter is clean, put the end of the catheter into a clean solution and occlude the catheter. This allows suction to occur. Without placing the catheter down, remove the cannula and set it in a clean solution. Insert the catheter about 4 to 6 inches. Occlude the suction and rotate the catheter as you are removing it. Rinse the catheter. Replace the cannula.
So one more tip when you are suctioning is, when you are inserting in, you will be sucking both secretion. Till you go beyond the tube, you will not be sucking the secretion. You will be sucking the air only inside the lungs. So ideally, what we do in our hospital is close or clamp the tube. Clamp the tube so there will be no suction here. Okay? Insert in. Once your patient starts coughing or there is resistance, then open the tube. Okay? And then take it out in a circular manner. So ideally, just a tube. You just close the suction tube so that there is no suction of air. So what you're sucking is basically the secretions and not the air. So the other cares would be related to the dressing. That is, you have to do a dressing mainly to make sure there is any no infections, and then the secretions are reduced and there is no pressure necrosis related to the tube and the traps. Ideally, the tubes to be changed after 72 hours, because once you insert the tube, it takes around 72 hours for the tract to form. Once a tract is formed, you don't need any instruments, even a basic person in the ward or even an attender will be able to put the tube back in. Without the tract being formed, it is very difficult for even a trained surgeon to put the tube back in. So generally for the tract to form, it takes around 72 hours. So once we insert a tube, generally after, since it's a foreign body, generally after 72 hours, we change the tube to a new tube. But in cases of emergency situations where there is a displacement or the tube is blocked, we may have to change the tube. In that case, the previous position, put the position in an extended position, the trachea will come up. Use any instrument in the ward. It may be an artery, it may be a dilator. If the dilator is available, just open that stoma. You'll be able to see the trachea because already the surgery has been done. Tissues will be dissected. Just dilate it, and then whatever tube. If you are not able to get the tracheostomy tube, there is no harm in putting any other tube we can insert. No, in emergency situations, sterility is not a problem. You can do with whatever dirty instrument which is even available in the dustbin. So in sterility, in emergency, sterility is not at all a problem. We can cover that always with antibiotics. Tube block, tracheostomy, slider is always an emergency. So sterility is not a prime importance in case of tracheostomy procedures. No, if you are not able to get a tracheostomy tube is blocked. That is the only tube there. What other tube you will be having in your emergency crash cart? Yeah. In your emergency ward, there will be always a crash cart, which will definitely have whatever size endotracheal tube. Okay. So just dilate that, and you can always put endotracheal tube till we can put the tracheostomy tube back. But put the smaller size tube. That will help you in putting the tube easily rather than a bigger tube. And then you need to cover with antibiotics, mucolytics to reduce the secretion. Analgesics in case of pain is there. And then if the patient is awake patient, when we breathe through normally, that is through the nose and the nasal passages, what it does is it does a filtering mechanism and then brings the temperature of the outside air to the body temperature. But once you breathe through the tracheostomy, that function is ruled out. So in case of that, if the patient is awake, you just put one wet gauze piece over the tracheostomy tube. And in case of patients who are on ventilator or who are weaned from ventilator, we use a HMV tube, or is also known as a Swiss nose. And the other thing is, if the patient is conscious, is in ward, once the tracheostomy tube is there, he will not be able to communicate. So you need to get communication from the patient as well as to the patient also. So ideally give a paper and a pen to the patient in case if he is able to read and write. So what are the complications we generally expect in the immediate period is apnea and aspiration, which will result in breathing difficulty, bleeding from the side, there may be collapse of the lungs, there may be damage to the vital structures, mainly the larynx, esophagus, thyroid, resulting in bleeding, great vessels, or to the recurrent nerves. There may be rare instances where there is a bulb of air which goes into one of the great vessels and then enters into the blood vessel system, resulting in air embolism. These are complications which are to be anticipated within the first 6 hours. In the next 6 to 24 hours, the complications which are anticipated are tube block, tube displacement, that is the tube getting displaced from the normal position, tracheal erosion, particularly seen in case of if the tube is, if the cuff is inflated with high volume, or in cases of tubes where metal tubes are used, or in cases of surgical emphysema, when the surgical technique is not done by a trained surgeon. wound infection, and then infection of the trachea and the lung. So the late anticipated complications are difficulty in decannulation. Decannulation is the process where we are planning to wean off the patient or remove the tracheostomy tube and close the tube. So that process is known as decannulation. So if there is any difficulty in decannulation resulting from tracheomalacia, this is one incident. This is a picture where I said tracheal suctioning is done as a blind procedure, done with plastic tubes. Where repeated injury, the above trachea is normal. The tracheostomy tube sits, you can see the mark here, but the obstruction is level below here. This is as a result of stenosis, that is narrowing of the airway occurring below the level of tracheostomy tube as a result of poor suctioning technique. There can be a fistula which is formed between the trachea and the esophagus or the skin. And finally, a slide on decannulation side. How do we do decannulation? Decannulation is a process by which where we plan or intend to remove the tracheostomy tube and give the patient the normal breathing tract. Here we insert the fullest tube or a fenestrated plastic tube and then occlude here. Either we can put a 10 ml syringe and occlude here or put a plaster here so that the patient breathes through a normal airway. The patient is able to tolerate for 48 hours. Then we remove this tube and then close using sutures. One more slide on pediatric tracheostomy is generally the pediatric tubes are very small size tubes. When the ventral is small, the chance of getting occluded is very high. The smallest tracheostomy tube available is 2.5. The largest tracheostomy tube which is available is 10. So the smallest size tubes is 2. But the 2, 2.5, 3, 3.5 and 4 are all uncuffed tubes. But above 4 we get cuffed tubes. So the lumen is small, so the chance of block is very high. So you need to be very careful when you do suctioning regarding pediatric tracheostomies. But in adult tracheostomies, we generally change the tube after 72 hours. But in pediatric, the tract takes around 2 weeks to form. So generally, when we want to change the tube in pediatrics, we generally change the tube after 2 weeks. So the take-home message is, I think we have discussed on tracheostomy, what it is. That is basically a procedure to relieve the upper airway obstruction. We discussed on the types of tubes, the post-op care, that is mainly the suctioning technique and the frequency, mainly on ventilated and in room air patients, the complications related to it, and then the decannulation process, and briefly on tracheostomy tube emergency. Thank you. Any doubts? Any doubts? Most of the time it is a central section. So we generally don't. When you connect it to the our question was what should be the suction. So most of the hospitals it will be a central suction. What we use in our hospital is a central suction. If you are using an individual machine, less than 100, not above 200. The more you suck, only the suctions are going to be very minimal. You are not going to expect liters there. Only so ideally it should be less than 100, not definitely above 200. Okay, thank you.
Thank you, sir. I invite our principal and vice principal ma'am to honor Dr. Gauri Shankar. On behalf of everyone It's a great pleasure to welcome Mrs. Surosmani to present the topic on ETT procedure, risks and recovery. Ma'am has done her post-basic nursing in MMC Chennai and a PG in critical care and nursing in MMC Chennai. Ma'am is a dedicated and compassionate nursing professional with over 2 decades of practical and teaching experience. She is a proven expertise in critical care, trauma management, maternity and burns nursing. Ma'am is skillful at leading clinical terms and facilitating educational programs with the focus on patient safety, evidence-based practice and community health. Currently, Ma'am is working as a nursing tutor in College of Nursing, Madurai Medical College and Hospital, Madurai. Ma'am, over to you.
Good afternoon, ma'am, principal ma'am and ma'ams. Good afternoon to all. It's a very good, effective. Yeah, you too happy. It's the end of session, my session. So, how to put a ETT. Morning session also, how the ETT, the indications and procedures are taken by all the teachers. I hope you are all there putting in a ICU setups or working in a ICU setups or putting a ET tube or tracheostomy tube. How many are putting the seat tubes? One or two. Confidently raise the hands. 1 or 2. Okay, no problem. I am also not working in ICU, critical care nursing, studying in all the critical care setups. Now, so we call for you following the classes. Introduction, it's an ET tube, how to intubate, then how to the endotracheal tube in situ, then cuff inflation to the pressure, the trachea, then esophagus, A, B, C, D, how to over the crunch. So, according to the procedure, nursing procedures of Sandhya Gai said, endotracheal intubation is a medical procedure in which they place into the pipe, that is the trachea through the nose or mouth, endo or oro. All about the upper airway and lower airway. I repeat it or skip it? Skip it. All the students are same. So I go to one story or like a for you. One guy get a state first mark for +2. So the name was newspaper, getting the newspaper or credit. எப்போமே +2 மார்க்கில் 10th ஃபர்ஸ்ட் மார்க் செகண்ட் மார்க் வாங்கினா பேப்பரில் பிரிண்ட் ஆகும். ஸோ நம்ம சிஎம் வந்து கூப்பிட்டு கிரெடிட் பண்ணிட்டாங்க. திருப்பி ரிட்டர்ன் வரும்பொழுது ஆக்சிடென்ட் ஆகிட்டாங்க. கோமா ஸ்டேஜில் அந்த பையன் போயிட்டான். 1 month டியூரேஷன் அவருக்கு ET டியூபு நம்மளோட ப்ரொசீஜர் வெண்டிலேட்டர் கேரில் போயிட்டார் கோமா போகும்போது. ஸோ ரெஸ்பிரேட்டரி மசில்ஸ் ஆல்சோ ஃபெயிலியர். 1 month ப்ரேயர் எல்லாருமே பண்ணுறாங்க, கேர் கொடுத்துட்டே இருக்கிறாங்க. டாக்டர்ஸ் சைடு கொடுக்குறாங்க, நர்சஸ் சைடு கொடுக்குறாங்க, அவங்களோட கூட இருக்கிற பேரண்ட்ஸ் சைடு. ஸோ தே ஆர் ஆல் ப்ரே in respect of religions. So Hindu religions, Christians religions, then Islamic religions. One fine day, 1 month away, the person is treated well, then come to the normal, conscious level. Whose prayer is on a recovery stage. We are giving a nursing care to the particular person. They know about the whole Tamil Nadu as our imagination. Which one is prayer is better? A recovery from him. Super. Nurses. Why? Why nursing prayer is recovery from him? care including care. Doctor's care is also included. Nurse's care is also included. Our prayer, emotional, little bit medicated, compassionate. I want simple term. Empathy, humanity, Manidam. Humanity basis, we are working in the along the patients. We are every time we keep it in our mind, humanity basis. That is the healing touch. Sir, humanity basis. Right. Right answers. Good. So on following conditions, indication or indication, respiratory arrest, respiratory failure, respiratory muscle failure, then airway obstructions, need to control and remove the pulmonary secretions, the need for prolonged ventilation support. The class 3 and 4, hemorrhage, the poor perfusion, severe flared chest or pulmonary contusions, inhalation injury with edema of the vocal cords, the protection from aspiration. All are set about the front features. Then supporting ventilation during the general anesthesia. Contraindication, you know about the severe airway trauma and neurological deficit. Already said that spinal cord injury. Then route. I take 2 routes, nasotracheal or orotracheal. Which one is the better? Easy to weigh? Orotracheal. Good. Airway assessment. Every time we assess the patient condition. Here, before going to EG tube, the quick assessment was done. So easy to the patient recovery time. So collect history, that any anomalies, the infections, tumors, any thyroid surgery or gland tumors, or brain or face or neck problems. Then preparing the articles. What are the section, airway, laryngoscope, the antiseptic lotion and adhesive tapes for placing the tubes, then introducers, stillets or Magellan's forceps, syringes, whatever it may, the 5 or 8 ml air, pushing the, inflate the tube. Then mucosal anesthetics, if it is patient is conscious. Water soluble, sterile, lubricant, gloves, oxygen source and connecting tubes, rigid pharyngeal suction tie-up, catheters, the knitted tube tape, stethoscope, cardiac monitor, pulse oximeter, adult blades 3 and 4, and connector. And many types of tubes is there, vortex tubes, rubber tubes, reinforced tubes. We are using the, which types of tube we are using in silicon tube or plastic tube, silicon tubes. Size also already told. Then position of the Atlando-occipital joint. So chin lift maneuver, otherwise known as the Atlando-occipital joint. This is the chin lifting method. But a neonatal condition is the same. But a neurological condition, neurological deficit or spinal cord injuries have a same position, or deep position is not recommended, always not recommended. Position, why we are placed the position? We show the glottis or open the vocal cord. It's a visualized correctly. That is the correct position. If it is not clear the sight, we put it into the injuries or anybody else. Techniques also, 3 or 4 techniques, mask ventilation, then topical anesthesia கொடுத்துட்டு அதுக்கப்புறமும் பேஷண்ட்டுக்கு வென்டிலேட் பண்ணுவாங்க. அந்த டைரக்ட் laryngoscope கொடுப்பாங்க, பிளேட் வந்து இல்லாமல். தென் கர்வ்டு பிளேட் டெக்னிக்ஸ், Then straight blade technique. We are using follow the steps, advanced and vocal cord, the tip of the technique. இதுதான் நம்ம follow பண்ண போறோம். The oral tracheal intubation also we are practiced in our setups. Select the proper size to tube, the 10 ml syringe that we done. Insert the அதேதான். Procedures is the same. During intubation, prevention should be trauma to the lips or oral cavity, tongue and teeth. Then vocal cord injury or esophageal intubation. Then pulmonary aspiration. If it is full stomach, means aspiration is possible. Then arytenoid dislocation. What's the meaning of arytenoid dislocation? Vocal cord is placed in a sides of curves. So that is the injury of the arytenoid. Arytenoid dislocation. We put it into the forced manner. The arytenoids can be damaged. They don't bronchial intubation, then we prevent the complications. The laryngeal stenosis are possible. The tracheal stenosis are possible. Accidental extubation, tracheostomy, fistula during pediatric groups. Then disconnection from the breathing circuit complications. After extubation, what are the complications may expect? Paralysis of vocal cords, necrosis of the trachea, then laceration of mouth, laryngeal granuloma, paralysis of tongue. Please, you know, aspiration. Very cause is about what type of aspiration we expect? Mucosal plugs or mucosal secretions and food particles. This is the common aspiration points we kept in our mind. Then endobronchial intubation. Esophageal. The tracheal intubate enters esophagus instead of trachea in cause of brain damage or death. Failure to secure the airway. After ET tube connection, immediately connect the oxygen. Or already mask is given and after ET tube intubation connected with the direct tube. So failure to secure airway, the infection later on, immediately is not possible. Immediately, if the patient receive the injury condition, suddenly it's not possible infection. Injury is a possibility. That we are not making furthermore injury. The problems coming out, anesthesia. The tension pneumothorax, the trapped air chest cavity can cause lungs to collapse. Recovery from the ET tube. Observe for abnormal sign and symptoms: soiled or loose tapes, pressure sore or nass, lips or corner of the mouth. Instead of the patient is playing same position for a longer period. Excess nasal or oral secretions. Tinkling the tubes also we are expected. Observe for the factors that increase risk of complications from ET tube, type and size of tube, movement of the tube up and down the trachea, the duration of tube placement, cough overinflation or underinflation, presence of facial trauma. The recovery from few hours or few days or few weeks, it depends upon the patient's condition. So sore throat, then swallowing difficulties, chest pain, breathing problems, shortness of breath, then prolonging coughing, then speech problem, swelling, face is also be expected. What are the factors affecting reasons for intubation? So, என்னென்ன factors இருக்கலாம்? Comorbid conditions. Then duration. எவ்வளோ நாள் patients இருக்காங்க, அவங்க vocal cord thicker ஆயிடுச்சுன்னா hoarse voice அது வரலாம். Then individual's health. immunity இருந்ததுன்னா recovery from the easy. So presence of complications also. Very short and not sweet, but very short. Already talking about our teachers. So we take in a okay,
First, எப்பவுமே always நம்ம என்ன பண்ணுவோம்? Say பண்ணிப்போம். ஐயா, hand wash. Come to form, back to back, finger locking, then down. Say fast. And rest rotate, right? But before that, I wash the hands. It's a not at the arrange the articles. Imagine after that. Selection of the assistant for order any volunteers. Come on. Volunteers. Patient எப்பவுமே இங்க வச்சு நம்ம பொசிஷன் பண்ணிருக்கோம். ஆசிக்கிட்டோ ஆர்லண்டோ so near by the patient எங்க ஷிஃப்ட் பண்ணிக்கலாம். Double down. Okay? So double down. The torch is also. Orlando, Asmin, position. Jaw, chin. Press. Position is a and video. And turn into the visible. You push it to the secure. Which line? Secure. It's a push it up. Push it down. Fast. Okay. Open. 5 or 8. See? Yeah. Slowly. You give it slow. Okay. Keep this fill. You remember it. The 5 ml gas is enough for this. Secure the tubes. Last. Take care. Always nurses the
searching the articles. The practical problem here is okay. Suction or audition. First. ஃபில் பண்ணுறதுக்கு முன்னாடி செக்யூர் பண்ணி பார்க்குறோம். அதில் நம்ம செக்யூர் நம்ம வோக்கல் கார்டு நல்லா ரிசல்யூஸாக இருந்ததுனால செக்யூர் பண்ணிட்டோம். நம்மளோட கான்ஃபிடென்ட் லெவல் செக்யூராக இருக்குது. வோக்கல் கார்டு ஓப்பனிங்காக இருந்தது நம்ம ப்ளேஸ் பண்ணிட்டோம். ஸோ அதனால தான் ஆக்சுவலாக ஆஸ்கல்டேட் பண்ணணும். இட்ஸ் இம்பார்ட்டன்ட் பாயிண்ட். ஸோ கான்ஃபிடென்ட் இருக்கிறதுனால நம்ம உள்ளே போயிடுச்சு. ஸோ நம்ம அதுக்கப்புறம் ஆம்பிள்கார் கொடுக்கலாம், இல்லாட்டி கனெக்ஷன் வித் வென்டிலேட்டர். Anybody else to see the open part of the procedure? Deputy? No. Why? So after removing the tube, deflate, secure the suction. The airway, clearing the airway, remove the tubes. Then after the removing the tubes, we are doing the fast surgeon right. Patient. Any police while doing the procedure? We are not doing practice or we are not doing the easy view in our services because of we are dependent. But ICU setup, if the needed patient, we do the on the days or we receive the patient immediately the incidental action. நம்ம சர்ஜனோட அசிஸ்டன்ட்டோட ஒப்பீனியன் வாங்க வேண்டாம். பேஷண்ட்ஸோட ரெக்கவரிக்காக நம்ம ஒர்க் பண்ணலாம். இன்சிடென்ட் ரிப்போர்ட் கன்சிடர் நம்ம அதை உடனே லைஃப் சேவிங் மெஷர்ஸ்க்கு நம்ம பண்ணிக்கலாம். ஸோ ஐ ஹோப் you should be put it into the YouTube in the future. Your life situation. Done.
Thank you, ma'am. We request our principal and vice principal to honor Mrs. Surosmani. Thank you, ma'am. It's time for tea break. We invite you all to join us with refreshments. So kindly assemble in the auditorium after 15 minutes. I request the delegates to take your refreshment over.
வீடியோவில் கரெக்டாக தான் பாருங்க.
On behalf of everyone, we happily welcome Dr. Jyoti Lakshmi, Professor cum HOD of Department of Pediatric Nursing, Velamal College of Nursing, Madurai, to give your valuable report.
A very good evening, one and all present here. I am so honored to be here. A very good evening, one and all present here. I am so honored to be here to propose observer report on this state level workshop. Let me first of all start by giving glory to Almighty God for making today's occasions a resounding success. I would like to thank our registrar, Professor Dr. Annie Grace Kalimari, for giving this opportunity to be an observer. Now time is running, getting late to go home, so I will take less time to read the observer report. Okay. Today, workshop theme is Airway Aware, Mastering Tracheostomy, Critical Care and Techniques. Registration started at 8:15 a.m. followed by lighting the lamp. First session started at 9:45 a.m. That is Unfolding the Life of Care, dealt by Dr. Arulmozhi, Principal, Preethi College of Nursing. Dealt about importance of 7 P's in Airway Aware. What are the 7 P's? Forgotten all those things. Preparation, pre-oxygenation, pre-treatment, paralysis, position and placement and post-intubation management. Okay. Next session started by Professor Sanmugapriya. Topic was navigating the difference between TT and ETT. Detailed explanation given regarding basic and advanced airway management. Then parts of tracheostomy tube and endotracheal tube, types of endotracheal tube, difference between TT and ETT. Next, third session started with brainstorming methods by Mrs. Uma, Vice Principal, Preethi College of Nursing. Topic was from invasive to independence. Mnemonic given. What is that? One mnemonic given. I win the so. That is initial criteria, weaning parameters and spontaneous breathing trial. Then explain about ABCDEF bundle. Then all the participants actively involved, all the participants, many delegates received smiley badge. Okay. Then tea break. We have a short break with tea and vada. Tea helps to reduce the stress and refresh our mind. After tea break, fourth session started by Dr. J. Suresh. Topic was TT tube and VAP care, that is ventilator associated pneumonia. Subtopics were indications for tracheostomy, history of tracheostomy, specialized cup tubes. Then ventilator associated pneumonia monitored by CPIS score and Jorgensen criteria. This session was excellent, sir. Thank you, sir. Then fifth session was critical airway compassionate care, dealt by Dr. K. Priscilla. Subtopics were airway at risk, tools in airway management, ETT suctioning, ventilator care, tracheostomy tube care, IRMI management and prevention for accidental decannulation. Then nursing care about nutritional management, oral hygiene, mouth care and communication. This session ended with 6 C's in critical airway patients. Then lunch break. It helps to restore energy. Even 30 minutes break can make a big difference in how you feel and perform the rest of the day. Next, all resource persons. Resource person's speech was clear, good eye contact with audience, good body language. Explanations were clear. In slide, text was readable, information was clearly arranged, right amount of information per slide. All the content were really valuable. This was an excellent presentation. The workshop was well structured, comprehensive, rich in content, and useful for all delegates. The arrangement of the workshop and the hospitality and commitment of the staff was highly appreciated. All topics were very informative and well presented. Thanks for organizing committee. Then after lunch break, sixth session dealt by Dr. Gauri Shankar. Topic was tracheostomy procedure. Subtopics were functions, indications, types of tracheostomy, post-operative care, complications and decannulation. decanalization. Few videos played in this session. This skill station was very nice. It will be very useful for all delegates in their future practice. Thank you, sir. Final session dealt by Mr. Surosmani. Topic was ETT, procedure, risk and recovery. This session explained with one scenario. Subtopics were indications, types of tube, position of patient and techniques, risk and factors affecting recovery. Demonstrated how to put endotracheal tube. Both skill stations were relevant and practical. The examples and case studies helped in understanding real-life applications. The resource persons were knowledgeable and explained concept clearly. Interactive discussions and activities kept. Participants engaged. This was an excellent presentation and practical session. Then every conference we prepare the program schedule. Here I found the creative program schedule. What is that creative program schedule? You have no. Only it was mentioned the QR code to subscribe the Preethi College of Nursing YouTube channel. I hope everyone did the subscription. Finally, I would like to thank this management, principal, vice principal, Preethi College of Nursing, Madurai. Overall remarks, well organized workshop in systematic manner. Thank you. Thank you for giving opportunity.
Thank you, ma'am. I request Mr. AY Zahir, Chief Operating Officer, Preethi Hospitals, and Dr. D. Sendil Kumar, Medical Superintendent, Preethi Hospital, to honor the observer. It's time for feedback session. We kindly request the delegates to share your feedback regarding today's workshop.
I am from CSI Jayaraj Annavakyam College of Nursing. Respected dignitaries on the dais and off the dais. ஸோ இந்த ஒர்க் ஷாப் ரொம்ப யூஸ்ஃபுல்லாக இருந்துச்சு. நாங்கள் காலையில் வர்றப்ப ட்ரக்கியோஸ்டமி கேர்ங்கிறப்ப ஜஸ்ட்டு யோசிச்சுட்டு வந்தோம். ஆனால் இங்கே வந்து நிறைய டெமான்ஸ்ட்ரேஷன், இடி டியூப் இன்டுபேஷன்லாம் பற்றி நிறைய எக்ஸ்பிளைன் பண்ணாங்க, நிறைய லேர்ன் பண்ணிக்கிட்டோம். திஸ் இஸ் மோர் இன்ஃபர்மேட்டிவ் ஃபார் அஸ். We learned a lot and the arrangement of this program is very nice. Thank you, ma'am. My special thanks to our principal, ma'am, Preethi College of Nursing, ma'am, Arunmozhi ma'am. Thank you, ma'am, for organizing this and giving chance to come here to attend this workshop. Thank you, one and all. We learned a lot from this workshop. Thank you.
Any other feedback? Apollo Hospitals. Velammal. See, from each institution, this will make us to serve better for the next. So please give your feedback.
Good evening to everyone. I am from Apollo Hospitals. நான் தமிழ்லே ஃபீட்பேக் சொல்கிறேன். நான் 4th இயர் ஓஜி படிக்கும்போது பெல்விஸ் அந்த ஃபீட்டல் ஹெட் இதுதான் நான் படிச்சிருப்பேன். பட் மேம் வந்து ஈட்டிலாம் படிச்சிருக்காங்க. அதை பற்றி நல்லா டீட்டெயிலாக சொல்லி கொடுத்தாங்க. வெரி தேங்க்யூ மேம். அதே மாதிரி அப்கமிங் ஒவ்வொரு செஷன்ஸும் நல்லா இருந்துச்சு. வைஸ் பிரின்சிபல் எடுத்த செஷன்ஸ் அந்த பிரெயின் ஸ்ட்ராமிங்ஸ் ரொம்ப நல்லா இருந்துச்சு. ஏன்னா நான் படித்தது அல்ட்ரா காலேஜ், சேக்ரட் நர்சிங் காலேஜ். என்னோட பீடியாட்ரிக் மேம் ஜோதி மேம் இங்கே தான் இருக்காங்க. அவங்களோட ஒவ்வொரு செஷனுக்கும் இந்த மாதிரி பண்ணிட்டு தான் ஸ்டார்ட்டே பண்ணுவாங்க. ஸோ இன்னும் அது நல்லா இருந்துச்சு. என்னோட காலேஜ் மெமரிஸ்லாம் எனக்கு நல்லா ஞாபகம் இருந்துச்சு மேம். தேங்க்யூ. அனஸ்தீசியாலஜி சார் நல்லா எடுத்தாங்க. அந்த நான் ஸ்கூல்லேயே ஹிஸ்ட்ரிலாம் படிக்க மாட்டேன், பட் இந்த ஹிஸ்ட்ரிலாம் சொல்லி கொடுத்து எனக்கு நல்லா பூஸ்டப் பண்ணி விட்டாங்க. நல்லா இருந்துச்சு மேம். அந்த ABCDEF நல்லா இருந்துச்சு மேம். தேங்க்யூ.
Good evening to one and all present here. First, I would like to thank Almighty God, and I would like to thank our principal ma'am. Thank you for giving this opportunity to participate in the conference. I extend my thanks to delegates and also the dignitaries. The programs was well organized. The conference was very useful for us, and that principal, vice principal ma'am, Uma ma'am take interactive sections very well. I really enjoyed it. And that especially anesthesiologist Suresh sir taken a classes in very well manner and very well explained. It's very useful for us. And my sincere thanks to our Professor Dr. Jyoti Lakshmi ma'am for this valuable observational report. I saw this report in my life. So this kind of valuable information and lot of observation ma'am told, so that is a very appreciable one. Thank you ma'am for your valuable observation report. I'm so proud of you. Now I'm a student, PG student. Thank you. The program was well organized. The hospitality was well good. Everybody is organized well. Thank you so much.
Thank you all. It's time for certificate distribution. Volunteers from each college are requested to come forward and collect the certificates when the name of their college is announced. I request all the dignitaries to distribute the certificates. First, from Velamal College of Nursing, Madurai. Next, Triple V College of Nursing. Followed by RAS Academy College of Nursing. Next, CSI Jaira Janabakim College of Nursing. CSI Jaira Janabakim College of Nursing, followed by Srinidhi College of Nursing. Followed by Sacred Heart Nursing College. Sacred Heart College of Nursing, followed by Apollo Hospitals, Madurai. Apollo Hospitals, Madurai, followed by Velamar Hospitals, Madurai. Next, Health and Wellness Center. Health and Wellness Center. Followed by Preethi Hospitals, Madurai. Thank you, dignitaries. Gratitude can transform common days into thanksgivings, can turn routine jobs into joy, and change ordinary opportunities into blessings. We are happy to invite Professor Uma, Vice Principal, Preethi College of Nursing, to deliver vote of thanks.
A very good evening to all. Before I propose a vote of thanks, I want to say about the pre-test and post-test results. We have conducted a pre-test in the morning before the session starts. Totally, this pre-test composed of 15 questions, and we have categorized the questions into poor knowledge, average, and the good knowledge. And in a pre, we got a less score, and there is a 0% in the good knowledge. And after the post-test, we evaluated all your answers. Around 88% has came to a good category. So this shows the workshop was effective. So with that, I start with the vote of thanks. No program or no things will end without saying thanks. So thanks is the word which cherishes everybody to welcome to the new program, right? And here I thank our management, especially our chairman, Dr. R. Shivakumar sir, then our managing director, Dr. T. Hema ma'am, to this in this moment, in their absence, I thank both of them. Thank you, sir, and thank you, ma'am. I thank our Chief Operating Officer, Mr. A.Y. Zaghi sir, for his valuable presence throughout the program and making effort to conduct this program a smooth one. Thank you, sir. And I would like to thank our medical superintendent, Dr. D. Senthil Kumar sir. So whenever we are asking for the demo session, any instruments, equipments, immediately sir could able to arrange it and make the things possible for a skill process and all. So especially we thank sir for at this moment. Thank you so much, sir. And I thank our respected observer, Dr. Jyoti Lakshmi ma'am. And as like she said, the detailed report madam has given to us. It was a motivating factor for us, ma'am. Thank you so much, ma'am. And I thank all the expert speakers from since morning up to the evening. They made you alert and learn many things. You're being stuffed and sent home. I think you have lot of things to take home message to your areas, right? Okay, so it should be shared with everybody. So whatever you learned today, please share with someone so that the knowledge will be widespread. Okay, I thank all the eminent and expert speakers present over here. Thank you all. Then I thank all the delegates from far. With everybody has a commitment, right? One day leave. I know how much it is difficult to get and to sit the whole day here. So especially I thank all your respective management and principal, those who took effort to take a permission and send you all here. And I thank the delegates also for their patience listening. They are all good listeners. Thank you. Thank you all. And my special thanks goes to our principal. Those who, she took all the effort to guide us. And many areas we used to commit நிறைய மிஸ்டேக்ஸ் பண்ணுவோம். அங்கெல்லாம் கூப்பிட்டு இது இப்படி பண்ணுங்க அப்படி பண்ணுங்கன்னு சொல்லி கரெக்ட் பண்ணி இந்த ப்ரோக்ராமை இவ்வளோ வெல் ஆர்கனைஸ்டாக கொண்டு போனது எங்கள் பிரின்சிபல் மேம். ஸோ ஸ்பெஷல் தேங்க்ஸ் டு அவர் பிலவட் பிரின்சிபல் டாக்டர் அருள்மொழி மேம். Then my thanks goes to all my faculty, dear colleagues. Without your tireless effort, this program will not be a successful one. I thank all the faculties of Preethi College of Nursing at this moment. Thank you all. And I thank all the students, those who took effort and making arrangement works and all. Fantastic. Thank you all. Once again, I thank everyone. Thank you so much.
Thank you, ma'am. Requesting all to stand for national anthem.
पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उज्जल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे.
Thank you all.